Good evening. This is Fred Margolis, and I'm a pediatric dentist in the Chicago area, and I would like to welcome you to Voco's webcast on aesthetic dentistry for tots and teens. In this webcast, we're going to teach aesthetic dentistry for primary teeth. We're going to show how you can go from the patient's picture on the left to the patient's picture on the right. Early childhood caries. This 3-year-old boy took a sippy cup to bed and slept with the cup at night for over 18 months. Alex said, "My teeth are dirty." His mother said, "The other kids are saying his teeth are dirty. Why are your teeth black? You look like a monster." She said, "No, for no other reason, just get it done." Creating smiles sometimes seems like magic. Open face stainless steel crowns. These are the step-by-step procedures. And these procedures can be followed if the crown's already cemented on. Perhaps the mother or father doesn't like the look, or the child, of the stainless steel, and you would like to make it more aesthetic. So you can do this at the time of the seating, or you can do it subsequently to that appointment. So the first thing you do is you prepare and try in the crown. You go ahead and open the face of the crown, and SS White has a kit called Pediatric Dentistry Preparation and Finishing Kit, according to Dr. Fred Margolis. This is the kit that I use for my hands-on courses and in my office. So open face stainless steel crowns. To remove the facing of the crown, you can use a cross-cut fissure burr, a diamond, or a 330 burr. Note, the gingival margin is left intact. And the reason for the gingival margin to remain intact is for strength and support and retention. So here you can see where you have a choice of holding the stainless steel crown in your hand or placing the crown on the tooth that you've already prepared and cutting the hole for the facing. Here you see that we can also open face stainless steel crowns on anterior crowns. Note again that the gingival margin is left intact. One of the cements that you can use is Miron Plus AC. This is one of the cements that can be used for the cementation of crowns, bridges, inlays and onlays made from ceramic, zirconium, or metal. It's a universal resin reinforced glass ionomer luting cement, and it comes in application capsules. What are the advantages? It's a self-adhesive. It saves time. No separate primer or conditioner is needed. It's thixotrophic, so you don't get unwanted runoff. No rotating instruments are needed for excess removal. And it's specifically suited for zirconia-based crowns and restorations. Open face stainless steel crowns. So after I remove the excess cement, I use a spoon excavator to do so. And I use a total etch technique. So during the webcast, when we talk about etching the tooth, we're going to etch both the enamel and or dentin. So here we're using, as you can see, the Voc acid, which is non-dripping gel. It's 35% approximately, orthophosphoric acid, and it's blue color for visual control. Notice that it won a 4-star award from Reality. Once the tooth is etched, rinsed, and dried, a bonding agent is placed, and then your composite. Now, being a pediatric dentist, you'll note that you can use any composite you so desire, but I use either an A1 or B1 shade for this technique. So finishing and polishing the composite facing. The picture on the left shows my favorite diamond, which is a spindle-shaped diamond, and it's used to remove the excess flash both occlusally, interproximally, and subgingivally. And then I polish the surface of the crown. Notice that this polishing disc, which happens to be made by Shofu, does not have the metal ring in the center, and therefore you don't get the black line when you accidentally touch the center disc area to the tooth. So this is the polishers that I like. Here's Sarah. This is 2 years after the open face stainless steel crown was completed. Notice the nice healthy gingiva. Sarah is now 10 years old. And here we can see, again, 2 years post-operatively, how nice and healthy that gingiva is. Also, notice that the margin, which we left intact, happens to be subgingival, and the gingival health is still very good. Celluloid strip crowns. So we're going to show you how you can go from the boy's picture on the left of his anterior teeth to the picture on the right. And this can be done in one appointment. Can we improve this 4-year-old girl's aesthetic and self-image? Well, I've been in practice 40 years, 37 as a pediatric dentist. I've never let a patient walk out of the office with stainless steel crowns on their front teeth unless they were open face or another type of crown or technique. For example, here the same patient with the celluloid strip crowns. Early childhood caries refers to both baby bottle tooth decay and nursing caries. And we all know that this is 100% preventable. Here's a child at a free clinic in Guatemala, and notice how unsightly the stainless steel crowns are on the anterior teeth. Here's an article that was published in December 2002 in Compendium, The Sandwich Technique and Strip Crowns, an Aesthetic Restoration for Primary Incisors. And by the way, on my website, www.fredmargolis.com, under articles, you can download this article and all the articles that I've had published, and they're in a PDF file. Here's Jenna. Jenna had early childhood caries, as you see here. In this case, I used an erbium laser to remove the caries and also provide laser analgesia. I teach a technique in my laser course through the Academy of Laser Dentistry and World Clinic Laser Institute, where the tooth is laser analgesia, in other words, numb, in 30 seconds. How numb is it? You can go into the pulp on a hot tooth, primary or permanent, with the laser if you so desire to do your pulpotomy. Sandwich technique. So first we remove the caries, then we use a glass ionomer or resin-modified glass ionomer. Then we go ahead and etch the tooth for 15 seconds and place a bonding agent. So here's the result with Jenna. Notice on the lower picture, we didn't have much to be concerned about as far as the occlusion is concerned. But this is immediately post-op, and you can see the beautiful result we got with the celluloid strip crowns and the sandwich technique and composite restorations. So here's her new smile, post strip crowns. Let's go through the step-by-step technique of the celluloid strip crowns. The picture of the central incisor, we're going to go ahead and show step-by-step procedure of how to go from the upper picture to the lower. The lateral incisor that's shown here, the right lateral incisor, has been completed at a previous visit. So we try in the crown form. These crown forms are made by different companies, several different companies, and they come in 4 sizes for the maxillary incisors, and you can use the maxillary left celluloid strip crown for the lower right central and lateral incisors, and vice versa. So you trim the crown form, and the cervical area always needs trimming. And then, as you see on the lower left, you place holes for venting, and this is to prevent air bubbles. We then place our composite into the crown form, and you can use any composite you so desire, and you set that aside under a black cover, and then you finish your preparation of the tooth. You then, once the carious dentin is removed, we etch bonding agent and go ahead and set that with the curing light, and then we place our celluloid strip crown. You see the excess composite on the lower left is being removed here with an explorer, some gingerly, and then we cure the entire celluloid strip crown with the composite underneath it. So here the strip crown is being removed. You can use a 30 fluted carbide burr, or as in this case, a sharp spoon excavator. For finishing and polishing, you use your polishing discs and strips, and again you can go ahead and remove the excess flash with the diamond. I use that spindle-shaped diamond, and here you see Demanto. Demanto is a series of composite finishers made by Voco. They're excellent for polishing composites. And here's the before and the after. This is immediately after the restoration is placed. And you'll notice that we don't have bleeding of the gingiva. If you do have some hemorrhage, you can use a product such as Viscostat to control the bleeding. Some people prefer a gingival retraction cord. I really haven't had much problem. I could also use my laser, either the diode or erbium laser that I have in the office, to help coagulate the area to absorb and remove and stop any hemorrhage. So here's nursing caries. This is Tamar. She's 2 years and 10 months old. Notice that she has caries on the upper incisors. She slept with mom and breastfed at night at will, and the mother's milk caused this situation with the early childhood or nursing caries in this case. So we place celluloid strip crowns on E, F, and G. So we used etchant, we use the Futura Bond U can be used, and also one of the composites that I like is the Ameris composite by Voco, and this happens to be shade A1. This is immediately post-op. So this is a close-up picture of the finished restorations. Those were done with the celluloid strip crowns also. So the patient on the left with the fractured primary teeth. Why should your niece, nephew, grandchild, or your own child go to school with chipped teeth where in 20 minutes you can place celluloid strip crowns on these teeth and get a beautiful result? Here's Sammy, age 4. He had class 3 caries on the upper central incisor and class 5 caries on the lingual of the upper left lateral incisor, as you can see in the lower photograph. My suggestion is on the class 3 not to try and restore it as a regular class 3 restoration, but go ahead and place a celluloid strip crown, because invariably the composite will start to chip right at the gingival margin. So here are the preparations. The tooth is being prepared, and in this case I'm using the erbium laser by BioLase, the Waterlase MD, without any anesthetic. You get laser analgesia from the laser. And here we see the celluloid strip crown and the lingual composite after they're finished. This took approximately 20 minutes. Here's Benedict, 3 years old, early childhood caries. You and I know that in the bottle, anything but water or a non-sugared liquid can cause the result of the baby bottle tooth decay, or in this case, early childhood caries. So what we want to do is the sandwich technique. This is a flowable composite called Grandioso, and Grandioso can be used after placement of the glass ionomer or the resin-modified glass ionomer. It can be used as a flowable composite. It is a flowable, and the other thing that you can do is place it in your class 2 restorations on the proximal box area as a base material before you place your final composite. It can also be used to restore minimally invasive cavities or caries of all classes, class 1 cavities and extended fissure sealing, class 2 to 5 cavities including V-shaped defects and cervical caries, blocking out of undercuts, lining or coating of cavities, repairing fillings, veneers, and temporary crowns and bridges. So Grandioso Flow is a light-cured, flowable, 81% filled nano-hybrid composite. These are the advantages: outstanding physical properties, strong enough for occlusal surfaces for small class 1 and 2 restorations, excellent color retention, wear resistance of a hybrid, excellent wettability, thixotrophic material that flows on demand, precise application with the long bendable tip, and natural aesthetics, an exact shade match with Grandio Radiopaque. So the sandwich technique. What materials bond to dentin? Well, glass ionomers and resin-modified glass ionomers bond chemically to dentin. You place this after your removal of the caries on these anterior teeth, for example, and you place them over the exposed dentin. Then you go ahead and etch. Here we're seeing the 35% phosphoric acid for 15 seconds, total etch technique. We then place a bonding agent after the etch is rinsed and dried, and this bonding agent that I'm showing here is called Futurabond U. It's dual cured for all light, and it's dual and self-cured resin material. So here's a picture of the Futurabond U. It's a single dose, and it has the dual curing adhesive. and it comes in these little packets, and it also comes with the micro brush. What about light curing? One of the lights that you can use is the Cellulux. Cellulux is a high-intensity, lightweight, cordless LED curing light. So again, you remove the celluloid strip. Do not leave the strip on. It causes gingival irritation, and eventually it will start to peel off. Notice the area at the mesial incisal and distal incisal aspects has the little blebs, or blobs if you will, of composite where you have vented the material. And here again is Benedict. This is the before and the after. So no anesthetic was used. We used the Waterlase MD for caries removal, first for laser analgesia, caries removal, and then we went ahead and prepared the teeth for the strip crowns. Here's a class 5 on a primary cuspid. The caries is removed. We use a resin-modified glass ionomer, again, to chemically bond to the surface of the dentin, and this prevents, or at least helps prevent, the composite from chipping away in 6 months to 1 year like it used to do for me before I started this sandwich technique. Then etch, total etch, wash, air dry, place your bonding agent, and place the composite. The most tooth-like composite, according to Voco, and I like the consistency of it, is Grandio SO. We then place for anterior teeth, I like to use either the cure through, as you see here, which is a plastic clear matrix. It's primarily made for cuspids and premolars, but often I'll take the smallest cure through, flatten it out, and use it even for upper and lower primary incisors. Garrison Dental, GDS, Garrison Dental Solutions, makes a cervical matrix called the Blue View, very similar to cure through, except it's tinted a blue color, so it's easier to see the contrast. So here's the cervical matrix being held in place after you overfill your composite material into the restoration, in this case class 5, and then you finish and polish the restoration. Here you can see on the left a 30 fluted carbide burr, and on the right you see my favorite diamond, the spindle shape, to remove the excess flash. We then polish the restoration, and this is the finished restoration. Notice the nice, smooth, shiny surface that can be obtained when using the Cure Through and Garrison Dental Solutions matrix system. Here's Akil, 4 years of age. Note the class 3 caries on the lower left central incisor, lateral incisor. And we're using the Waterlase MD for laser analgesia and to remove the caries and prepare the tooth. No anesthetic was used. And here's Riley, age 3. Here we had again class 3 caries on the lower incisors. Using the laser to remove the caries without anesthesia. What are my clinical goals? A restorative material with proven performance, high polishability, lifelike aesthetics, strong physical properties, and excellent handling for universal applications. Here we can see the Grandioso composite shown on the right. Notice that it comes in compules and also syringes. Ameris is one of the composites made by Volco. What are the optical properties? It has translucency, fluorescence, and opalescence. It has high polishability and low surface roughness. It has color stability. Consistency is soft, non-sticky. Polymerization properties, you get a long working time and individual curing. Physical properties are well established. Posterior composites at the same or above the other composites, and they call it intelligent shade management. It's non-complex, exact, correctable, and powerful. High aesthetics with high demands. Here's a 5-year-old male, fractured primary lateral incisor. Let's go ahead and restore this tooth with our celluloid strip crown. So we're going to go ahead, and as I mentioned, we're going to use a maxillary left central incisor strip crown, lateral incisor strip crown for the lower right central and lateral incisors. So we use the upper left lateral celluloid strip crown because they do not make strip crowns for lower incisors. So here's the try-in of the celluloid strip crown. We're going to go ahead, etch the tooth, bonding agent, and place the strip crown with composite. Notice the little bleb of excess composite. And here's, after finishing and polishing, the completed restoration. So what's different about enamel in primary versus permanent teeth? When I was at Ohio State University School of Dentistry in the 70s, we were taught that we could not bond to primary tooth enamel. And the reason for it is because of the aprismatic or non-prismatic layer of enamel. The good news is that that layer is approximately 20 to 40 microns. Now the human eye, according to my eye doctor, when I used to see 20/20, the human eye, the smallest we could see is about 70 microns. So here we go, and we're going to use either an erbium laser, or we can go ahead and use a fine polisher like even pumice, or I like a fine diamond with copious amounts of water. I'm not sure pumice will do it, but the diamond and the erbium laser will remove that 40 microns so we can go ahead and bond to the tooth. So since we're bonding the teeth, why not do composite veneers and freehand them, as you see here on this patient's upper left central incisor. So you see the gray tooth on the left versus the tooth with the white veneer on the right. The father only wanted me to do the darker tooth first, and then a couple weeks later I knew he'd come back, and sure enough he wanted me to do the other central incisor. I wanted to make note here that just because the primary tooth is dark, as I've written an article and had it published on the dark primary incisor, does not mean that the tooth has infection or is abscessed, as we'd say. It means that when the trauma occurred within the blood cells, there is a substance called hemoglobin. We call it heme for short. And when the heme escapes from the capillaries, it causes the discoloration. That color may return to normal within 2 months. So here's a dark primary incisor. We want to go ahead and remove the aprismatic layer of enamel, which can be done again with the erbium laser on the surface of the tooth, or we can use a fine diamond burr. We then etch, place an opaquer, bonding agent, and composite, and you have a choice. You can place your bonding agent before or after your opaquer. So here's Gretchen, 3 years old, Notice the dark primary central incisor on the upper left. We're using the laser to remove the aprismatic layer prior to bonding, and then we go ahead and use our etch bonding agent and composite. And this was done freehand, and you can see what a nice result we got. Notice the healthy gingiva is maintained. Here's another very dark purplish brown tooth on a primary incisor. Again, why should this patient go to school and possibly be teased about the discoloration of this primary central incisor when in 20 minutes we can go ahead and place a beautiful veneer for this patient. This one's a little too light. This was extra light by Dentistry, and it's the TPH. But we can place our opaquer after the etch and finish our composite restoration and polish it. So what are the shortcomings in adhesive dentistry? Postoperative sensitivity, incompatibility with self or dual cured materials, inadequate etching and adhesion of the SE adhesives, and excessive film thickness. Post-op sensitivity. So here what we want to do is make sure that we seal the open tubules, because the open tubules would lead to post-op sensitivity. Also, there's rapid fluid movement in the tubules, disturbing the nerve endings, therefore inducing pain and discomfort. So what are the causes for sensitivity? The open tubules left unsealed, polymerization shrinkage, which causes stress of the composite, which can cause debonding, which can result in microleakage and formation of the fluid-filled gaps. And lastly, bacterial infiltration via microleakage. Shrinkage. So these are different materials and that we use in dentistry from different companies, and you can see here that Ameris by Voco, in this case, in this study, showed the lowest amount of shrinkage. What are the physical properties of Ameris? They're higher than competing aesthetic composites, at least equal to the established posterior composites in strength and shrinkage. Ameris is well suited for posterior use as well, but that's not the focus. Here we see aesthetics without compromise. This is the shade concept. Shows the different shades that the Ameris comes in, and you can see it compared to the Vita Shade Guide. Here we're going ahead, and Grandioso Flow or Ionoseal can be used as a sealant. The Ionoseal is a light-cured resin-reinforced glass ionomer liner that can be used as the sealant. Here's Grandioso Flow used as a sealant. And this is an example of where you would use the Grandioso Flow composite. So here's a lower left second primary molar, and you can see the caries on the occlusal buccal and the final restoration. So composite to stainless steel crowns. We are very, very blessed in dentistry, pediatric dentistry especially, to have now crowns that have pre-formed, baked-on composite for all 20 of the primary teeth. One of the company's brands that I use is New Smile. So they're available now for all 20 of the primary teeth. And by the way, let me mention that as of last year, they had codes for resin-covered stainless steel crowns for primary teeth. And this year, which I'm going to be showing, there are at least 3 companies that make all zirconia crowns for all 20 of the primary teeth. And the ADA does have a code for the all porcelain crowns for primary teeth. So these are the stainless steel crowns with the composite baked onto them. These are the new smile. This is 3 weeks after seating the crowns. This is on a 3-year-old, early childhood caries. The lateral incisors were abscessed and had to be removed, but we were able to save the central incisors. And you notice the health of the gingiva after only 3 weeks. Here's Jenna. She's a 4-year-old with cerebral palsy. Here are the new smile crowns that were seated 18 months prior. And we try our best, but sometimes it's not enough. We know that about 30% of children have bruxism habits, and we go ahead and I'm showing here a primary molar that has a composite covered stainless steel crown, and you can see where the composite has chipped off. On the other hand, here's a new smile crown 30 months after seating, and notice the nice healthy gingiva. Amalgam versus composite. Which would you rather have for your child? The silver amalgam restoration or the white tooth-colored composite? We give the parents a choice, and we explain to them what the difference is. Here's the preparation for a Class 2 composite in primary teeth. To me, this is minimally invasive dentistry. Some people have asked me during lectures and after by email about doing tunnel preps. The problem with tunnel preps on these teeth is, number 1, are you removing all the caries? How do you know? And number 2, the weakening of the marginal ridge. I'm very concerned about children chewing on ice or hard candies and breaking that marginal ridge. So here are the Class 2 restorations. And basically, I followed Dr. Gordon Christensen's example when I saw him do a live television program several years ago at the Chicago Midwinter meeting on his 8-year-old dental assistant's son. And he did 2/3 Compomer, which we'll talk about, and 1/3 composite. So the Compomer was placed because it was felt that it's going to absorb the fluoride that you place in subsequent fluoride treatments, and also has the effect of bonding chemically to the composite layer on top of the Compomer. Here we can see S.S. White's burr kit. And here we see a close-up of one of the polishers. These are called the Jazz polishers. Here we can see the various polishers. Voco has a set of polishers called Demonto. These are T-bands that are shown here. T-band is a brass matrix. They come in different sizes. I like to use the 0.001 inch, which is the thinnest matrix in the T-band variety, and also the narrow and straight. They have a curved and they have wide for permanent teeth, but the straight, narrow, and 0.001 inch. Here's an application technique for large restorations, class 1 and 2. Preparation is finished. Etch, bonding agent, flowable composite, and then you go ahead and layer that with a sandwich technique with other composites such as Grandioso, and then light cure each increment of universal composite. Here's Vertice Flow. This is a flowable composite. As you see here, and this flowable can be used in the proximal box to seal and make sure that you have all the margins sealed and the tubules are sealed. And here we can see a composite placed over the flowable composite. In this case, it's the Herculite Ultra. And here's the completed restoration as shown in this picture. Here's the real matrix. This is one of the matrix systems that's very unique, and it comes with the handle, as you see here, the real matrix handle, and you can get the real matrix in both a 5mm size, which is the one that I use for bicuspids and primary molars, as you see here, and it also comes in a celluloid strip material with the real matrix. So you tighten the matrix and you do wedge the matrix to get good contacts. Garrison Dental Solutions also has a segmental matrix system, and in every audience I ask, when I'm lecturing, I ask if the segmental matrix gives the dentist the best contacts they've ever had, and everyone says yes, absolutely. This matrix is by Garrison Dental Solutions. It was first made, especially made for pediatric dentistry, I feel, because it's a gold-plated matrix system, and they have several others that I like now. Notice that you do wedge after you place the matrices, and you can do one tooth at a time, or you can do multiple teeth. And this is called the Composite Tight Gold Matrix System by Garrison Dental Solutions. Voco has curvy wedges. These curvy wedges are plastic, and as you see on the lower picture, it comes in different sizes and widths, and these are all color-coded. So you see various examples here of the curvy wedges. Again, with Class 2 preparation and restoration of primary teeth. Here on the left you can see the preparation of the Class 2 caries, and in the middle you see we're using one segmental matrix and a wedge to get a nice contact. You can do these either back to back or one at a time, as you see here. And on the lower right, you see the finished restorations. These V3 segmental matrices are now sold through Ultradent, and it's made by a company from New Zealand called Triodent. And here's their contact information, triodent.com. And notice that this matrix system has a locking pliers that comes with it, like a cotton forceps, with locking device, and it also, the matrix has holes and slots so that you can align the matrix and for easy removal. The plastic wedges, some people like them, of course. I prefer the wooden wedges personally because I feel they're more comfortable for the patient. And also when I use my topical anesthetic, when I'm doing laser dentistry, the topical would be absorbed by the wooden wedge, make it more comfortable for the patient. Here we're showing the use of smart burrs too. These come in size 4, 6, and 8. These are plastic burrs, and the nice thing about these smart burrs too is that they will only remove carious dentin, not sound dentin. So it removes the infected, not the affected dentin. Here's an article from Compendium from November 2001, and it's called The Aesthetic Space Maintainer. And the word space should be in parentheses. And the reason for that is because once the primary cuspids, maxillary and or mandibular, erupt, there is no loss in the width from the mesial of the cuspid to the mesial of the cuspid. That doesn't mean that one or two remaining incisors will shift slightly, but the overall leeway space is maintained. So here we see early childhood caries. This is baby bottle tooth decay, and you and I know that this is 100% preventable. This is Arthur, age 5, and unfortunately these teeth had to be removed. So what can we do for these patients? Here's a 2-year-old with early childhood caries, and we see here that these teeth immediately post-extraction, and here are the teeth that were removed, the 3 incisors. So what can we do to restore the functionality of these teeth, prevent speech problems? If there are more than 2 maxillary incisors missing, there can be a lisp, and also we want to restore aesthetics. So here's a step-by-step instructions for an aesthetic maintainer. I use stainless steel crowns on the first primary molars when the first primary molars are available. The reason I do that instead of using the second primary molars is because you get a shorter fulcrum arm so that the pontics don't go ahead and move gingivally and incisally while the patient's eating. If the patient already has stainless steel crowns on these teeth, we can fit pediatric dental molar crown bands, over the stainless steel crowns. So here's a patient that is missing the upper 4 incisors due to either trauma or due to caries, severe caries. So we place preformed stainless steel crowns that are pre-contoured, and you get the smallest size that will fit. No tooth preparation is necessary. I will repeat that. No tooth preparation is necessary, and that's because the periodontal membrane or periodontal ligament is wider in children, and you'll notice that the occlusion will adjust. These are only 1.5 millimeters thick on the occlusal surface. So after trying in the stainless steel crowns, we take an impression, remove the crowns. You can use compound impression material or alginate, and then you can place 1 drop of super glue, either the liquid or the gel, on the buccal and the lingual of each crown that will go ahead and attach it to the cement it to the alginate. Even wet alginate, it works. and that's to prevent the crowns from moving when you pour up the model. You can also use alginate, which is an alternative by Kerr. So this avoids a lot of messy cleanup and saves time. So smiles are important. This boy, shown with Uncle Fred, that's what my patients call me, has had the 4 maxillary incisors extracted due to severe caries. And let's go ahead and take a closer look. So here's what he looked like after the maxillary incisors were extracted. Notice also that he had to have his first primary molars extracted, which were done, and this was done under general anesthesia, and the crowns were seated and the impression taken. Notice that this is a 2-for-1. I call it a 2-for appliance because it has not only the aesthetic maintainer but also the Nance holding arch. So we would go ahead and we would cut here and here when we're done with the aesthetic maintainer, and that would leave our Nance holding arch. So here he is again with Uncle Fred and his nice new smile. So when to remove the space maintainer? We know that about 6 to 9 months after the lower incisors erupt, we're going to start to see the eruption of the permanent incisors. So how do we remove it? I take a cross-cut fissure burr and I go ahead and slice through on the buccal from the occlusal to the margin of the stainless steel crown, even if it's subgingival. I used to use a spoon excavator, and one of our friendly pediatric dentists emailed me after a previous webcast and said that we could go ahead and go to Radio Shack and purchase for 50 cents or $1 an all-metal screwdriver such as this, and I use that to pry apart the 2 halves of the crown and then pop it off to remove it. What about ankylosed primary molars? Well, I was taught that if the primary molar is more than 50% submerged, then we should go ahead and do something about it and treat the situation. Here we see a first primary molar that's approximately 50% submerged. We are starting to lose some arch length here. You can see a little bit of the first permanent molars erupting there. And on the patient's left side, we have about 30% of ankylosis, as you can see here. No one knows exactly, at least I've never seen any documented proof of what causes ankylosis, but we do see it quite often in our patients. So we have several treatment plans that are fine to use, and it's your choice. You can place a stainless steel crown, you could place an aesthetic crown over this tooth, you can go ahead and build it up in composite, which is what I did in this case. You can extract the tooth and put in a space maintainer. So here's the tooth again from an occlusal view. And how high do you build it up? Well, we can go ahead and etch bonding agent in composite. You can purchase celluloid strip crown forms in primary molar size now and shape, or you can freehand it, which is what I have chosen to do. So again, we etch the tooth with our phosphoric acid gel, rinse it, dry it, bonding agent, and then add your composite and sculpt it, set it, and polish it. So here's the final view from the buccal, and notice the occlusion. So the marginal ridge is going to tell us how much of the tooth to build up. and how high to build it. Bruxism. We said that about 30% of children brux. So here we make the bruxism appliance for the lower arch instead of the upper arch. Then we don't get the gagging that we would get if the appliance were used in the upper arch. Now the upper arch, of course, the mouth guards are made for athletics, for sports, as a mouth guard. And I took a computer and made this little habit busters chart. So we use positive behavior modification techniques for toothbrushing and pacifiers, and also thumb sucking, and in this case for mouth guards. The other little skinny, as we used to call it, is go ahead, let the patient pick out the color they want. We make this in our office on the heat vacuum machine after the impression's taken. The patient decides what color they want at the time of the visit, and then they come back a week later and we seat the mouth guard. And I suggest to the parents, same thing with orthodontic retainers, that the children start wearing them about a half an hour the first 2 weeks before going to bed, so it gets them used to the appliance so they can fall asleep more easily. So for severe bruxism, as in this case, this is an autistic child, and we had to go ahead and prophylactically place stainless steel crowns on these teeth due to, as you see here, due to the severe bruxism. And I build these crowns up about 1/2 to 1 millimeter higher than the occlusal plane to help prevent the abrasiveness on the permanent molars. Sealants. I hope you're all doing sealants. I've been doing sealants now for over 30 years, and this is a well-placed sealant, and we want to go ahead. If you get excess material when you're placing this sealant, you or your certified assistant or hygienist, depending on what state you live in, you can go ahead and take a Q-tip, a cotton-tipped applicator. For example, let's say that there's too much sealant on the distal aspect, distal margin, which happens sometimes. You want to remove it before setting the sealant or having it set. Then the Q-tip will help absorb the extra sealant material. So that's another little skinny, as we say. Triage. Triage is a glass ionomer sealant that's made by GC America. I like the Triage. I use the white color, and where I use the Triage sealant is for 3- and 4-year-olds. We have difficulty maintaining a dry field, and also for partially erupted molars. So here we can see the pink sealant on the right. It's actually about a salmon shade. And here's some primary molars that had ClinPro. And the ClinPro is by 3M SB, and it starts out as pink, and when you put the curing light on it, lo and behold, it turns white. So I do seal primary molars. I tell the parents that usually the insurance companies will not pay for sealants on primary molars, but I feel that if they have deep pits and fissures, this is going to help prevent, as you see here, this is going to help prevent caries on these teeth. UltraSeal is another great sealant. What I like best about the UltraSealant is the drying agent. It contains both acetone, so it goes in between the enamel rods, cleans the enamel rods area in between very well, and then it also has a material that will bond to the sealant. It's an unfilled resin in the material that is the drying agent. So even if before I used the UltraSeal, I would have my hygienist or certified assistant place a bonding agent and make sure that the bonding agent was placed in order to chemically seal the sealant material to the bonding agent after it's etched. So why use a sealant? Well, what we want to do is we want to go ahead and make sure that those pits and fissures are filled with our sealant, because even as you see here, the toothbrush bristles can't get into the depth of the grooved areas. So this happens to be Voco's sealant. It's called Grandiose Seal. And here we can see some photographs taken, scientific pictures that show the depth of the sealant and the depth of the pits and fissures there, the fissures especially. What about fluoride varnish? Yes, I use a fluoride varnish on both the children, and I also use it for my teenagers and my special needs adults, because we want to go ahead and help prevent the caries. Dental Volunteers for Israel. This is a voluntary program in Jerusalem, and they have over 20 countries represented. The dentists go ahead and exchange for providing the free treatment on the underserved population of Jerusalem. The patients are referred by social service agencies, and the clinic is over 30 years going strong, and it's named after Trudy Berger. Trudy was a Holocaust survivor, and she decided as a teenager that if she survived the Holocaust, she would do something for the children of the world, so she established this clinic. As you can see, I was much younger the first time I went to the clinic. If you want to volunteer, you can contact me and I will get you the information of how to volunteer. You do not have to be a pediatric dentist. There are general dentists and orthodontists and endodontists and so forth that go ahead and volunteer to do 1, 2, 3, or 4 weeks of volunteer work at the clinic. Courses in laser dentistry. Here I'm teaching a course, a hands-on course, and these are certified through the Academy of Laser Dentistry. This happens to be a standard proficiency course that I give in Chicago through my teaching institute as a recognized provider from the Academy of Laser Dentistry. And later this month, we have our Academy of Laser Dentistry 21st anniversary, and we're going to be meeting in Scottsdale, Arizona at the Radisson. And they have participation courses, laser safety. You can take your standard proficiency course, which is a 12-hour course during this program, this conference. It's going to be from February 27th to March 1st. So if you're interested, you can go ahead and log on to www.laserdentistry.org. Dr. Larry Kotlow, Rashida Jaju, and Dr. Sun, Grace Sun, we're going to be giving a full day of pediatric dentistry on lasers at the Academy meeting on Friday of the conference. I'm very proud to have published a textbook. The publisher was Quintessence, Giovanni Olivi, and Maria Daniela Genovese, a husband and wife team from Rome, Italy, were my co-authors, and it is available through Quintessence Publishing. My contact information is my email, KIDZ as in zebra, DR, at Comcast.net. So if you think of any questions and I don't have time to answer them during this program, you can email me. And again, my website for my educational institute is fredmargolis.com, www.fredmargolis.com.